Hi folks, welcome to my YouTube channel. So in this video, we will discuss about what is a neuroendocrine tumor and what is the neuroendocrine carcinoma and how to differentiate these two entities and what is the significance of differentiating these two entities. So first, according to the WHO classification of the neuroendocrine neoplasm in the GI and into the pancreatobiliary system, it encompasses three entities. The first is the neuroendocrine tumor, which is further divided into G1, G2, G3, which is known as the neuroendocrine tumor. And the second category is the neuroendocrine carcinoma, which is further subdivided into the large cells and into the small cells. And the third category is the mixed neuroendocrine, non-neuroendocrine neoplasm. So first we will discuss what is the neuroendocrine tumor. So the neuroendocrine tumors are a group of uncommon tumors that arises in the neuroendocrine cells. These cells combine the traits of the nerve cells and hormone-producing endocrine cells. So basically, these neuroendocrine cells, these are embedded into the different organs, such as into the pancreas, lungs, GI system, and other systems. So these neuroendocrine cells, we cannot see them through radiology or through gross description or through gross examination. We can only see them under the microscope or microscopically, which is in contrast to the those endocrine organs which we can see radiologically and grossly, such as thyroid and other major glands. These tumors are quite uncommon. Their incidence is 1 per 100,000. They have the wide range of occurrence, but they most commonly occurs from third to sixth decades. They occur commonly and equally in male and females, and they are commonly associated with the variety of the syndromes, such as the main one, von Hippel-Lindau syndrome, neurofibromatosis type 1, and the tuberous sclerosis complex. So this is the typical cytology of the neuroendocrine tumors, so which is known as the famously as the salt and the pepper type of the cytology. So we have a small nucleus which has the clear chromatin, which gives them the appearance of the salt, and then we have the prominent tiny nucleoli which give them the appearance of the pepper. So this is known as the salt and the pepper type of the cytology. So this is very important to know that there are multiple morphological variants of the neuroendocrine tumor in accordance to the anatomic locations. These morphologies become some much more significant and paramount whenever we are dealing with the metastatic lesion and we do not know where is the primary tumor located. And it has been seen on the metastatic site the tumor could be of the 10 to 15 centimeter large, and the primary lesion could be only the 1 centimeter. So it is important to understand what are the different morphological variants of the neuroendocrine tumors in terms of their anatomic locations. So in terms of a small bowel, they commonly form the large nested type of the architecture. In the center, we have the loose small cells which are commonly surrounded by the eosinophilic palisading type of the cells, and in the rectum they commonly form this trabecular or insular type of the pattern with this pseudo stratification of the nucleus, and in the duodenum they form the pseudo glandular type of the architecture, and sometimes we have seen the somoma bodies as well, while in the pancreas, they commonly form the solid type of the lesions, and histopathologically, they form the loose, discohesive cells with this salt and pepper type of the cytology. So according to the WHO grading system, so the neuroendocrine tumors are further subdivided into the G1, G2, and G3 according to the Ki-67 proliferation index and according to the mitotic count. So it is very important to remember that even though we have a G1 in the lesion, or even though we have a G3 in the lesion, they all are phrases as the well-differentiated neuroendocrine tumors. And another thing important to remember here is that we have to choose the correct hot spot, and we have to count 500 cells equal or greater than 500 cells to label the Ki-67. Why it is important to choose the hot spot, we will discuss in our subsequent slides. So this is one of the example of the heterogeneity of the grading within the same tumor. Why it is important to choose the hot spot? Because these tumor shows the spectrum. So in the same lesion, in one area, we could have a G1, and in another area, we could have a G2, and in the different area, in the same lesion, we could have a G3. So it is important for us to locate the correct hot spot, to count at least 500 cells to correctly label the grading of the tumor. And this is another example of the neuroendocrine tumor where they shows the lower grade and in the higher grade in the same lesion. So on the right hand side, we could see that there is some pseudoglandular type of the architecture with the salt and pepper type of the cytology, and the stroma looks halonized, while on the right hand side, we can see that there is a high NC ratio. There is no any pseudoglandular type of the architecture. Looks like it's a solid type of the architecture with these pseudo stratifications of the nucleus, and the stroma is not halonized, or stroma is losing. And then we have the readily available or identifiable mitosis. So this is one of the important example that we have the spectrum within the same lesion. And when we see the tumor is going from this area to the higher grade area, this phenomena is known as the grade progression in the neuroendocrine tumors. And another example of the grade progression is on the basis of the punctate necrosis. So again, on this left hand side, we see some pseudoglandular architecture, salt and pepper type of the cytology, some capillary formation in between the stroma, while on the right hand side, we could see this punctate type of the necrosis, which emphasize or which shows that the tumor is progressing within the same lesion, and it is going from lower grade to the higher grade. And now coming to the neuroendocrine carcinomas. So the first contrast between the neuroendocrine tumors and the neuroendocrine carcinoma is the origin. So the neuroendocrine carcinomas, they by definition, they are poorly differentiated. These represents the neoplastic entity that is genetically more closely related to the conventional carcinomas. So it's especially talking about the GI tract, or even in the pancreatobiliary system, the glandular epithelium can give rise to the large cell carcinoma, and squamous epithelium give rise to the small cell carcinomas. It is important to remember that the neuroendocrine carcinomas are always high grade in nature. So practically there is no need to grade them. They are always poorly differentiated, and they are always high grade in nature. So in terms of our pathogenesis, so the hypothesis of this lesion is that the conventional counterparts such as the adenocarcinoma or the squamous cell carcinoma, they commonly have the high turnover rate. So during their divisions, they acquire more and more mutations, and when they acquire more mutation, especially mutation in the TP53 or RB gene, and to some lesser extent such as KRAS, BRAF or APC and other genes, they will transform from the original conventional part to the neuroendocrine carcinomas. And in one of the study, it was seen that the KRAS mutation, which is very common in the pancreatic ductal adenocarcinoma, it was seen that when the ductal adenocarcinoma was transforming to the neuroendocrine carcinoma, it still harbors the KRAS mutation, which supports this hypothesis that the conventional carcinoma transform into the neuroendocrine carcinoma, which is always a high grade and is always a poorly differentiated. This is the pathogenesis of the poorly differentiated neuroendocrine carcinomas. So the glandular or adenocarcinomas, they commonly transform to the large cell carcinomas, and squamous cell carcinomas, such as from the esophagus or from the anal tract, they commonly transform to the small cell carcinomas. This is not a hard and fast rule. There could be some exception, but this is the normal phenomena how the transformation occurs. So clinically, it is important to remember that the neuroendocrine carcinomas, they grow rapidly and they grow quickly. While the radiology plays the important role here, so the radiology could help us to differentiate between these two, because the neuroendocrine carcinomas are always high grade in nature. So the PET scan always shows the high avidity, they light up, and while the octreotine scan is almost negative in the neuroendocrine carcinomas, which is in contrast to the neuroendocrine tumors, because the octreotine scan detects the somatostatin receptors, which are only expressed by the neuroendocrine tumors, but not by the neuroendocrine carcinomas. And why it is important to differentiate these two entities? Because the neuroendocrine carcinomas, they are highly refractory to the chemotherapy, they only respond to the platinum-based therapies, and their survival rate is very, very low, and it has been seen in the less than 25% of the people. The survival rate is hardly of the 2 years. So this is the histopathology of the small cell and the large cells. So the small cells, histopathologically, microscopically, they have the high NC ratio, they have the dark nucleus, and they hardly have any cytoplasm around them, and they shows the molding as well, and the high grade features such as the punctate necrosis and the mitosis, they are readily available or identifiable. And the large cells carcinomas, they have like a polygonal type of the architecture, because they have the abundant and the high amount of the eosinophilic cytoplasm in them, which give them the shape of the polygonal type of the architecture. They always have the high Ki67, and they commonly lose the RB gene expression. So in this example, we can see the internal control of the stromal cells. They have the intact expressions of the RB gene, while the tumor or the lesion itself losing the RB expression. So this is the WHO grading of the poorly differentiated neuroendocrine carcinomas. So the important thing here is that there is an overlap between the G3 of the neuroendocrine tumor and the neuroendocrine carcinoma. They both have the same grading scale. They both have the greater than 20% of the Ki67 and greater than 20 count of the mitosis. So it is important to remember that the grading is not helpful to differentiate the neuroendocrine tumors versus the neuroendocrine carcinomas. And how we can differentiate between these two entities on the basis of the histopathologically features. So some clues which could be helpful to differentiate between them is that on the left hand side we have the poorly differentiated neuroendocrine carcinoma, and while on the right side we have the neuroendocrine tumors. So the poorly differentiated neuroendocrine carcinomas, here in this picture we can see that there's an infiltrative lesion which is having a stromal reaction in form of the desmoplastic reaction, while in the neuroendocrine tumors we have the discohesive type of the architecture of the tumor, and we have the pinkish and the hyalinized stroma, but there is no desmoplastic reaction around them, and this hyalinized stroma is formed by the hyalinized vessels around them. Another clue to differentiate them is the small vessel arrangement. So on the left hand side, we hardly see any capillaries traversing in between the tumor cells or in between the lesion, while on the right hand side, which is the example of the neuroendocrine tumor, we can see that the capillaries are traversing in between the tumor cells and trying to give them the architecture of the nested appearance. So how we can approach these lesions and how we can differentiate them, as we discuss, the treatment plan and the survival rate is totally different for them. So before even we go over the histopathological features and the help of the ISCs, the clinical information in terms of the history and in terms of the radiology is highly important. So in the neuroendocrine tumors, they are commonly the incidental finding without the high-grade malignancy associated with them, and they grow slowly and gradually, and they sometimes express the elevated plasma neuroendocrine markers such as the chromogranin A, and they shows the diffuse avidity on the octreotide scintigraphy because they express the somatostatin receptors. While in contrast, the neuroendocrine carcinomas, they develop rapidly, they grow rapidly, and patient is commonly not doing well. So there will be the high grade malignancy associated symptoms, and there will be elevated plasma carcinoma markers, which make sense here because they transform from their conventional carcinomas such as adenocarcinoma or the squamous cell carcinoma. So they have the high level of a CA 19.9 and the CA 125, and they show negative or weak and focal avidity on the octreotide scintigraphy, while they light up on the FDG PET scanning. And then after this clinical information, and if under the microscope we are seeing the high grade features in the neuroendocrine neoplasm, high grade features includes the tumor necrosis, as we see the punctate type of the necrosis, increased mitotic activity, and the high Ki67. So the first thing we need to do is to see, is there any additional material available for the patient? Because as we said that the neuroendocrine tumors, they shows the spectrum. So we could have the G1 or the G2 in the past, and now the tumor has progressed, which is called as a grade progression, and now we are dealing with the G3. While it is very much important in neuroendocrine carcinomas, because there could be the history of a conventional adenocarcinoma or the squamous cell carcinoma. Even besides the GI, this phenomena has been well studied in the breast. It has been well studied in the prostate as well. And then the ancillary immunohistochemical studies are very helpful to distinguish between them as well, because the neuroendocrine tumors, they commonly shows the loss of DAXX or the ATRX expressions, while the neuroendocrine carcinomas, they shows the loss of RB or they shows abnormal P53 expression. And as we discussed, the management plan between the two entities is different as well. So the common treatment for the neuroendocrine tumors includes sunitinib, mTOR and inhibitors, and the somatostatin analogs. While for the poorly differentiated neuroendocrine carcinomas, it is the platinum-based chemotherapy. So the takeaway points from the discussion is that these two are totally the different entities with a different outcome and a different treatment plan. So the neuroendocrine tumors, on the basis of Ki67 and the mitotic rate, they are further divided into G1, G2, and the G3. They are slow growing and may have a relatively better prognosis. Their treatment includes surgery, somatostatin analog, targeted therapy, and the peptide receptor radionucleotide therapy. While the neuroendocrine carcinomas, they are always poorly differentiated and high grade by definition, so we do not need to grade them. They are always high grade in nature. They are aggressive, rapidly progressive with a worse prognosis, and only response to the platinum-based chemotherapy. So it is important to keep these two entities in mind, especially when we are dealing with the small biopsies, because it could be challenging to make a distinction. However, the whole clinical presentation, radiology, IHCs, and if there is availability of the molecular studies, then it will be helpful to differentiate these two entities. So these are my references, and this is the end of my presentation. So thank you so much.